Hi and welcome to GreenGP. Today I'm going to be talking about approach to the chronic cough in general practice. Chronic cough is one of the 5 most common symptoms presenting to family practice. It has a wide range of causes and most are minor and self-limiting, but as always the GP must consider serious causes. It's a protective reflex with elements of voluntary control and may in fact be psychogenic, and chronic cough refers to a cough that's been persisting for more than 8 weeks. The most common causes of chronic cough are listed in the top 4 there. Upper airway cough syndrome used to be referred to as postnasal drip and encompasses allergic sinusitis, chronic rhinosinusitis and bacterial sinusitis. And obviously a few other common causes of cough include asthma, reflux and post-infectious cough. Post-infectious cough can have paroxysms of coughing triggered by even minor factors like hot drinks or strong smells, but of course is preceded by an acute respiratory infection. Other causes of cough may still need to be excluded, however, for example, asthma triggered by a viral infection. And as we know, paroxysmal cough can also be persistent for a long time after an acute whooping cough infection, so still important to consider that one. Parenchymal lung disease refers to COAD, interstitial fibrosis, bronchiectasis and sarcoidosis, and some infections not to be missed include TB and a lung abscess. In approaching the patient with chronic cough, a thorough history is probably the most important feature, which is the case in most of general practice presentations, or most medical presentations for that matter. It's really important to ask about temporal associations with the cough, so for example a recent upper respiratory tract infection and the timing of the cough. So if it's nocturnal, for instance, this could represent postnasal drip or UX, asthma, or perhaps even left ventricular failure. The character of the cough can be helpful. For example, a brassy cough represents possibly tracheitis or bronchitis. A barking cough might be croup. A bovine cough might represent vocal cord paralysis from recurrent laryngeal nerve palsy. And also really important to inquire about any associated symptoms and constitutional or systemic symptoms like tiredness, weight loss, fevers and sweats, wheeze, nasal discharge, substernal burning pain after eating, and breathlessness. And breathlessness would be more frequent in cases of asthma, COPD, or left ventricular failure. Alarm features, I won't go through all of them, you can read those, but clearly if they're coughing up blood, that needs thorough investigation, and smokers are at higher risk of serious causes of cough. If there is significant shortness of breath, that does suggest a more significant cause for the cough, and if there's significant sputum production also, that requires further investigation with imaging and sputum MCNS. Complicated GORD refers to that associated with weight loss, anemia, gastrointestinal bleeding, dysphagia or odonophagia, or even failure of empirical treatment with a PPI. Examination of the patient with chronic cough is usually unhelpful, but it can be a bit useful in pointing towards specific causes like bronchiectasis, interstitial lung disease, cancer or chronic infectious disease. And the 3 most important investigations to consider in these patients include a sputum MCNS if the cough is productive, an early chest x-ray, which will usually be normal in these cases, however, will at least show any major pathology in the lungs, and spirometry testing, which these days is fairly easily arranged in most general practices. So it's important, if there are any identifiable causes of the cough, to use specific therapy as the initial step, clearly, but sometimes it's not clear what has caused the cough, so a therapeutic trial is reasonable if there are no alarm features. For instance, trialling a proton pump inhibitor or an inhaled corticosteroid. If the patient is on an ACE inhibitor and the cough seemed to commence after the commencement of the ACE inhibitor, it's reasonable to trial ceasing that if appropriate. And it can take up to 3 months though for that cough to resolve. Usually it resolves within sort of 1 to 4 weeks, but there can be that time lag. And if the patient has a history of asthma, also really important just to check their compliance and whether or not they're actually using their preventers appropriately. And if you're considering that UX or post-nasal drip diagnosis, then a trial of nasal corticosteroids, antihistamines, avoiding allergens, and possibly even antibiotics if it's a bacterial sinusitis may treat the issue. If you failed one of those therapeutic trials, it's worth considering further investigation if the cough is persistent. So if you're still going along the lines of these top 3 sort of causes of chronic cough, then further investigation is listed there. So sinus CT scan for UX. Asthma, really again just checking compliance and avoidance of allergens, and endoscopy for those with probable reflux. Other investigations, if there's still no clear cause, and at this point you'd be probably considering referral to pulmonary or ENT services. So high resolution CT scan of the chest, a bronchoscopy, and best practice from BMJ actually suggested iron studies because apparently iron deficiency can lead to a chronic cough, which I was unaware of. They're my references for today. I hope you found this talk helpful. I still feel there are some grey areas in approaching the patient with a chronic cough, but clearly most of the diagnosis will be in the history. So listen to the patient, listen to those temporal associations, and if there are no alarm features, then consider a therapeutic trial. Thanks for listening.